I'm Jan, obviously, and I figure while folks are filtering back in, I'll give some introductory information. We are now a chapter of the Mastocytosis Society. So if I say the letters TMS, the TMS, I'm referring to the Mastocytosis Society. I'm really glad we could do this because this is to tide us over. I'm really hoping that we can get a conference out here sometime in the next year or two. We couldn't do that until we became a chapter. So I lobby, and now that we're showing an increased patient attendance and activity, we might actually be considered for a conference in the next year or two, as I said. The last one in our area was in 2012 in Bellevue, Washington, and for those who don't know me, I have both Ehlers-Danlos Syndrome and Mast Cell Activation Syndrome, and very mild POTS, which is postural orthostatic tachycardia syndrome, a subset of dysautonomia, which seems to be the love child of those two conditions. This is my website currently on the screen. And I have been gathering all the best information on both conditions, or all of them actually. So if you miss anything today, two things are true. One is we're trying to record this, and the other is I will post my slides on my website later. And you want to take a look at, sorry, it's hard for me to see this screen, even louder. So up here, up above, my homepage, I always have like whoops, that's not my homepage. I said home. There we are. I always have current news and events at the top of my homepage, but my reference materials, so this column about EDS is all the hottest tips and ways to suspect and how to diagnose EDS. There are tips for doctors that cover both conditions. The things that we in the groups, so I've been kind of assimilating what people in the groups, and I'm in groups of thousands. There are thousands of people from around the world with all of these conditions. So I feel like a reporter from the field. I'm channeling my cohorts out there. There's a lot of us. And so I've been, gathering and kind of distilling our chief complaints, if you will, like what we wish you guys knew, what we can use help with the most. So this is handy tips for doctors. And then I also have over here so there's resources, which is for Ehlers-Danlos, and including recommended books and finding support and helpful gadgets. And over here is what is MCAD, and I have a brief introduction, to get people used to kind of the terminology and what it encompasses. But my MCAD resources page is where I really urge people to go all the time, and I repeat it all the time, and then I keep finding people to look at it. At the top I have the best websites from where I've gained information to start with, and just underneath that, a fellow patient named Lisa, it's either Klimas or Klimas, Klimas. She's a brilliant blogger, and she is also a patient and a scientist. She's not a doctor, but she's a smart scientist. She's got some of the best write-ups of both how to diagnose and differentiate, and an overview of mast cell disorders. And she's constantly posting, she reviews the literature and posts a lot of stuff from there. So I strongly urge reading these 3 links for everybody. And then I go into anaphylaxis information. The TMS has an emergency protocol. So for patients, both the special edition of the chronicles that I gave to the doctors, and if nobody else shows, the rest will go to the patients here today. That special edition is a summary of the condition. So by the TMS, the leading nurses and researchers. We have a PhD who contributed. So I also have that posted right here. So if somebody doesn't get a physical copy, it's available in PDF. And you can also send patients here, and they can get their own copy of this special edition and give it to their doctors. Also, the TMS emergency protocol is here. And I urge all patients to pull that down and fill it out with your doctor. It's got great information on how to be handled in the ER, and it lets you list all your medications and what kind of reactions you're having, things that you need to avoid, because we are the patients that break the rules, as you'll learn today. We are the exceptions. We are the black box warning people. If anybody can react to something, it is us. We are the canaries in the coal mine. And then I go on to list other of the best articles that doctors will want to read and drill down on, because this is currently, it's a moving target. Even the best researchers today, everybody's still defining the condition. And the TMS, there's this committee on the TMS who is a very brilliant committee, very hardworking, who are trying to get some ICD-10 codes out for this, which will help everybody, because then doctors have a hook to hang the information on and a diagnosis to give you, and patients, also can say this is really real, there's a code for it. So I hope that you'll take advantage of this information. I also have down here, the way that I discovered I had this condition is, so I got diagnosed just over 3 years ago. I'm 48, and in 2012, I'd like to say the world wasn't coming to an end, just my world as I knew it. Little did I know, I was going to go from walking to wheelchair in 3 weeks with a storm of onset of my Ehlers-Danlos Syndrome. I'd had lots of trouble in my life, chronic fatigue, joint pain, fibromyalgia type pain, reactions, but everybody just kind of blew me off, dismissed me, called me a wimp and a woman and depressed, handed me SSRIs and, suck it up, buttercup, keep going. So, I stopped complaining. I mean, you get dismissed by enough doctors and friends and that you just stop talking about it and you just do what you can. And I'm so glad I did. I traveled and I got to do some photography. Because little did I know, I didn't get a memo that I was going to go down in 2012. So, bless my doctor who'd had me for 15 years off and on. In his defense, and all the doctors' defense, they've only been told about the grossest signs of the rarest types of both conditions, for the most part. So, of course he didn't recognize it, because, I'm standing here, I look good, and I was active and healthy looking, but all my pain is internal and invisible, all my reactions are internal and invisible. I don't have any spots, unlike some of my colleagues who are here today. And out there on the internet, hello everybody. We know you would be here if you could, but there's a lot of people who are housebound today and or in the ER, sadly, or the hospital, coping with this condition. But I stumbled on one night when I was reacting to alcohol that I drank to knock myself out to sleep because my upstairs neighbor had dropped, it sounded like a bowling ball on the floor. I was reacting, breaking out. And I stumbled on the mastocytosis symptomatology video. And so it's here on my website, broken up into 3 parts. It's on YouTube available. So they were handing it out on DVDs, but you don't have to worry about that. It's available here on YouTube. So again, on my MCAD resources page, I've really tried to gather all the very best info. And then there's additional other useful articles and info. I also have Wendy's website. She's the histamine reducing diet. Wendy will be speaking later. We're really glad to have her down from Alberta, Red Deer, Alberta, Canada. And I want to also thank Todd Mortensen from Nutricia has joined us today. He's in back with the table because the product line that they have, this Neocate product line, actually is a product of last resort for some of our patients. Some of our patients, not all, thankfully, but some of the most afflicted patients end up losing all of their foods because they have such severe reactivity and literally can't have actual recognizable food protein. So this is one of the most elemental formulas out there. A friend of mine said, well, can't they just take Ensure? And the answer was no. It would kill some of us. because of the additives and the products it's made with. We have, for some reason, a lot of corn allergy in our group. Not everybody, but those who have it, some of them have it extremely severely. I just added information on corn allergy down at the bottom of this page. Comprehensive list of corn allergies, and up in the ER section here, by the emergency protocol, I have the emergency protocol for those with severe corn allergy, because as I click on it, you can react to things like the ethanol swipes in the ER. We just had a patient up in Seattle who was reacting, and they were trying to keep her alive. She had sepsis, had to be treated, but thank heavens one of our members was able to be there and help guide the doctors and let them know, get that out of here, put that away, or wipe that up, because she was reacting to some of the treatment. And nobody, you guys can't help it. You don't know this. We don't come with warning labels saying, no ethanol swabs. I do recommend everybody get some of the lovely jewelry that I'm wearing if you're one of these patients. I have two, because as I learned in a car accident 2 years ago, it was a blessedly mild accident, but I because of my Ehlers, I'm so plastic that in this low impact rear end accident, I felt my skull slip forward and snap back on my spine. I literally felt it go forward and back. So Kaiser entered me into the trauma unit, and I was the slowest trauma, slowest speed trauma you'll ever see. But thank God I was lucid, because despite my bracelet with the cloth band, thankfully I was speaking, because as they rolled me into CT, I said, "You aren't going to shoot me with iodine by any chance, are you?" Because I was just about to. So clearly one wasn't enough. So my other one reads anaphylactic to iodine. And when you get your medical ID, very few people know what mastocytosis is. Very few people know what Ehlers-Danlos is. So listing those sadly doesn't help us. I dream of the day when we can list mastocytosis or Mast Cell Activation Syndrome and Ehlers-Danlos Syndrome, and everybody knows what it means. It's really, we need to. We're going to get there. But until we do, focus on what you're most anaphylactic to. The one I have with the bracelet has an online record as well, but they don't have time to look at your online record. That's for later when you've stabilized, and you can list, you yourself can put more complex detail in there. So, but when you're out in the field and squished and can't talk, you want to make sure they've got the most important information, like what not to give you. That includes, by the way, in EpiPens, some people do react to the preservative in epinephrine autoinjectors. So ideally, I think we should just stop making it with preservative, but I guess it doesn't last as long. But just be aware, patients can react to the preservative in the EpiPen autoinjectors. So we are those crazy-making patients. We're going to make you pull your hair out, and we're not trying to be difficult. It sucks for everybody, patients and doctors. But again, we're grateful because Nutricia, their line of products are one of the few that some of our patients can actually consume, because it's elemental enough to avoid triggering any reactions in some people. So feel free to later during a break, and I realize I didn't schedule any breaks, but during Q&A, I'll probably stop for a break. And my friend Peter will be back to run for us if anybody wants food. There's a cafe that's a fair bit of a schlep. I'm offering to send Peter to fetch food for you. Hopefully you brought your lunches as I requested. There we go. So getting on with the show. I also want to be sure to thank all my fellow patients online. You guys are tremendous, because I've learned everything I know from the TMS at the conference in 2012. So I got lucky and I found that the conference was happening right before it happened, and I went and attended because, understandably, again, my doctor hadn't heard of this, and Kaiser Allergy only knows about mastocytosis. So if you don't have gross signs like a really elevated tryptase and some other signs, they don't think you have any issues, and they're just not aware yet. And so I realized I'll go educate myself and then educate my doctor, and he's with me. We're a team, and happily, thanks to all the information I've gleaned from the conference and the patient groups, I'm doing pretty well. So I've already kind of talked about who I am. Again, I had that storm of onset that helped me to get diagnosed with both conditions. Finally, like I had an answer for all my pain and struggles. I ended up leading the Oregon Ehlers-Danlos Syndrome support group, who, by the way, are having a support meeting at 3 o'clock today by coincidence. I didn't mean to back-to-back this, but if anybody's got the energy and interested, they meet at Good Health Physical Therapy over on Southwest Shoals Ferry, next to the Raleigh Hills McMenamin. It's a physical therapy office run by Heather Curtin, formerly Heather Goodell, and she's brilliant. She has Ehlers-Danlos and is a brilliant physical therapist. So we've been sending a lot of patients her way who need the help with Ehlers-Danlos. You can follow me on Twitter, and you can follow me on my blog, as I've already mentioned. Disclaimers: I'm not a doctor. I'm just a well-read, pedantic patient who's good at gleaning and distilling information and willing to get up and speak. This is going to be a very high-level introduction. I'm trying to cram a lot in here. I apologize if this is kind of goes quickly or overwhelms anybody. But again, we'll have time for Q&A, and I'm going to post the slides on my website. We're trying to record this as well, so we hope to have some results there. So what I want to start with is terminology, because I see a variety of uses of the terms in the online groups, and there's understandably a lot of confusion around it, because there's kind of no governing body, even though the TMS is out there, and they're as close to a governing body as we get. There's no single entity saying, use this, do that, say that, so to speak. And so in my study of the literature, so this is what I've concluded, is I'm seeing the bulk of the specialists in those documents, which are posted on my website. These are some of the documents. They use the term to mean MCAD, Mast Cell Activation Diseases, to be the umbrella term for the whole collection of mast cell activation disorders. You'll see, I say that because I see a lot of patients use MCAD to mean one of the subsets. The new diagnosis on the block, Mast Cell Activation Syndrome. So, 20 years ago, 30 years ago, we were still figuring out mastocytosis, and when some smart doctors figured out to ask, people were autopsied and they were finding mastocytomas in them and patches of mast cells, and to realize, where were they before that? Oh, they came in with anaphylaxis, idiopathic anaphylaxis often, meaning idiopathic means of unknown origin. But then they started seeing patients who, to paraphrase the brilliant Dr. Afrin, walk like a duck, quack like a duck, and I like to add suffer like a duck. Thank you very much. But we're negative for mastocytosis, and I'll be getting into the biology in a minute, but broadly speaking, mastocytosis involves too many mast cells that are also overactive. Mast cells are essentially allergy cells. They're what give you your allergies and allergic-like reactions. In Mast Cell Activation Syndrome, your patients will be negative for elevated tryptase perhaps, and they may or may not show other elevated mediators, depending on how well you try to capture them. But they're sick as dogs. They're just as sick as a masto patient or an allergy patient. They may be negative for allergies, but we're negative. We've excluded mastocytosis. So we're coming up. This is the newly emerging diagnosis is Mast Cell Activation Syndrome. And the S and the D are right next to each other on the keyboard, so people can probably think that was a mistake. So you'll see MCAD used to mean MCAS by patients. And I'm not going to slap any wrists on that, because in the end, you're suffering the same way. It's the activation that's getting you. So the key difference is mastocytosis is a distinct entity involving proliferation, excess mast cells throughout the body. So just want to make that clear. I'm going to use MCAT as the umbrella term, just to be clear. These documents are all under my resources on my website. So what does it look like? When do you suspect this? Some common signs. These are not all the signs by any stretch. I want to toss out bone pain while I'm at it is a common experience that I don't have listed here. But one of the most telltale signs and the most easy to see is easy flushing red of the mantle. The mantle being your chest, your neck, and your head and ears. You may or may not, the whole mantle may not flush. You may just get, it can look like lupus sometimes. You can get the butterfly rash, what looks like a butterfly rash, and people will get misdiagnosed with lupus. Yes, some people will have lupus, but we can look like we have lupus and we don't. You may get blotches. It might not be a thorough covering, so you may not have a thorough red covering, but you may have blotches and splotches. Sometimes just one side of your head or your face will turn red. Another very common sign are hives, which are the medical term for patients is urticaria. And these hives come and go. They may last a few days. You'll break out in response to the myriad triggers I'll be talking about, and they'll itch, but they'll go away, and when they go, they don't leave any telltale residue. There's no, stain or spot left behind, as opposed to urticaria pigmentosa, which is a special form of hives that are persistent. They're hive-like patches that persist, and this is a sign of a cutaneous form of mastocytosis. So I like to say hives come and go, urticaria pigmentosa accumulates. When you start to get spots that don't disappear and they itch during reactions, and they may darken or turn bright red during reactions, but they'll fade, but they don't go fully away, suspect urticaria pigmentosa and see both a dermatologist and an allergist. Dermatographia is the word for skin writing. During reactions, some people can, when they scratch themselves, the skin will not only turn red, but in some people it'll also raise. You'll get a wheal, W-H-E-A-L, a raised wheal. I'm going to show you pictures in a minute of a lot of this. IBS is extremely common, irritable bowel syndrome, all forms, all types, including constipation and quick flips to diarrhea. And in fact, if you kind of have that combination, that's a real telltale sign to me. I'm convinced IBS is just the catch-all for food allergies and mast cell activation disorders and intolerances and histamine intolerance. It's really common. All of this is driven by excess histamine, gas and bloating. A lot of people get rid of constipation when they remove gluten. Even if you're not celiac, you can be just sensitive, and people find their constipation improves off of gluten. But we can react to other things and get constipation. I suffered all my life. Frequent or sudden nausea or vomiting in reaction to triggers. And it's not always foods. That's one of the distinguishing things between this and food allergies and sensitivities. We're going to react to a lot of things that I'm going to get into, including anesthetics. I vomited for days after most of my surgeries, and including I had a minor operation right across the street here years ago, and he said it would be no worse than getting a tooth pulled. Well, yeah, it was easy, it was painless, but I didn't stop vomiting for the next 3 days. Ended up in the hospital here. And nobody said, oh, pay attention to the anesthetic you used. So sadly, my records are shredded, so I still don't know what the culprit was. Nobody thought this was odd. They just said, oh, that happens to some people. Esophageal spasms. I get nutcracker esophagus, it's called. If you stress me out when I'm eating, I can eat normally, and speaking of which, if Peter's here with my olives, I'll take the olives. I have to constantly snack. Thank you so much. These will keep me going. If I'm stressed when I eat, so take a safe food, I might have a safe food, and if I'm calm, I can eat it just fine. But you stress me out or put me in a hurry, or I have elevated histamine for whatever reason, I may get this esophageal spasm, and it's extremely painful. Your esophagus seizes on the food. It literally clamps onto it. It's not going up, it's not going down. You can't get anything through your esophagus, period. And you just have to stay calm and write it out. Very painful. I can breathe through my nose at those times as long as I remain calm enough. I'm lucky. I don't tend to have airway involvement, but for those who do, this can be a real problem. Pain, and I did mention bone pain. I guess I did throw that in at the last minute. So asthma and your typical signs of allergy, itchy runny nose, itchy watery eyes, and some of us, our lungs will run. I can be going along and talking, and suddenly my lungs will just start running and I'll start coughing. And it's not an asthma, it's an actual runny lungs. It's kind of bizarre, but that's how it goes. Is a sign of a beginning reaction. Headaches of all kinds. We are the migraine queens and kings, sadly. But especially, we get a lot of pressure headaches from increased cerebral spinal fluid. I call them brain juice headaches. And when you toss in Ehlers-Danlos Syndrome, we're realizing some of us that can press your brain back. A lot of us have pseudo-Chiari. We have Chiari malformation is when your hindbrain sags out the back of your skull at the bottom. And we're learning that some people have really bad Chiari symptoms without herniated tonsils. Others will have herniated tonsils without signs. And some of us will have a pseudo-Chiari, and it acts up when the brain pressure increases, when you get extra fluid on your brain and it's pressing it back. I'm one of them. During the height of my storm, I had central nervous system apnea. So everybody's heard of obstructive apnea of the airway. And as you can imagine, Ehlers patients have floppy airways, even if we're thin. So regardless of weight, you can have obstructive airway apnea if you have floppy tissues. And we're finding these two comorbid. I'm going to get into that in a minute. Commonly comorbid, so this isn't uncommon. But during the height of my storm, I had cranial cervical settling and a lot of brain juice, and so I think it was impinging my brainstem and causing me I had to remember consciously to breathe in the daytime. That kind of surprised me. As one of my doctors said, "You mean you have to recruit your frontal lobe to breathe?" And I said, "Yes." Thankfully, it's resolved with a lot of nutritional work with vitamin C for me. Angioedema, which is swelling in the tissues, commonly around the lips or the eyes. Your eyes can swell shut. You'll often have a little bluish or purplish tinge to it. A lot of us get it in the abdomen. Those of you who get a lot in the abdomen might want to rule out hereditary angioedema. We've got a couple patients who suffer from that as well as the mast cell disorders. It's a specific genetic problem involving another part of the immune system that allows that to happen. We'll have sudden variations in blood pressure, both high and low. So while most doctors and EMTs and nurses are aware that, to look for our crashing blood pressure during anaphylaxis, a lot of us will start with a spike. And they've been surveying in the TMS conferences, and when they ask, how many of you get blood pressure spikes, show of hands, quite a few do. In fact, I'm sure some people here do. Yes, I'm one of them. But then it will drop later, or sometimes it just drops. So that's news to some medical people I know, because they usually think of only drops. Well, we can spike as well. Raciness, hyperadrenergia, notice my fast thought, fast speech, anxiety, trouble falling asleep and staying asleep. Often histamine driven. Histamine keeps us alive and awake, but too much keeps us a little too awake. We will have lots of paradoxic reactions. We're those people with long lists of medication reactions and food reactions. So when you've got patients who are reacting to almost everything you give them, I suspect them. And what I find interesting is, technically allergy, you can't react the first time you encounter something, and yet we say, tell me what medications you're allergic to. And we're responding to something the first time, so I find that interesting, a little pedantic point of issue. Commonly allergic to bees and wasps. This is the Hymenoptera family. And if you are allergic to bees and wasps, you will often be allergic to iodine contrast, as I found I was. I had an IBP when I was 14 to rule out kidney trouble, and went anaphylactic on the table. Thankfully, they shot first and asked questions later. I'm alive, I'm fine. But that's something to be aware of. Also, we're often sensitive or reactive to alcohol. And this last line is what helps me to differentiate this from allergies, because you can't have an IgE protein antibody to, heat and cold and vibration and sunlight and stress. We are very sensitive to stress. This is a stress-induced and driven illness. A lot of us get onsets or flares and get diagnosed after a lot of trauma or stress. And interestingly, Ehlers-Danlos responds the same way. So we're starting to wonder if the mast cell mediators may not be driving some of the tissue laxity in Ehlers-Danlos. This is unverified, but everybody's kind of wondering. We're circling the same drain. I promised pictures. Here's some pictures, including yours truly, in the middle there when I was having a reaction with a flushed face. That was my arm in the upper right after my car accident, after a day in the hospital. We often react to the adhesives, like EKG adhesives, various tapes. This poor child on the lower left, his eyes are swollen shut. He's not shutting his eyes. They are swollen shut. I know, I've been there and done it. The poor little baby down at the bottom has a fine display of urticaria pigmentosa. And the good news there is a large percentage of cases of children with urticaria pigmentosa, the cutaneous mastocytosis, they may spontaneously remit. They'll go into spontaneous remission around puberty. So there's some hope there. Not everybody, but a good percentage. Meanwhile, it makes for a great teaching opportunity during our measles outbreaks when parents, mastomoms, get to explain that not all spots are measles and we're not contagious. So purpura and petechiae are also common. They're not diagnostic, but they're common. And there's some skin writing on the bottom right, the dermatographia that I described before. I saw somebody drew a picture of a mast cell on their back. I thought that was kind of cool. It's not contagious, as I said. However, the Mastocytosis Society does recommend we maybe not give blood or organs in case we have bad mast cells that we're sharing. You're going to learn, I'm about to explain how they're throughout our whole body. They should not be living in your blood. This is a white blood cell that doesn't stay in the blood. It moves into your tissues. You should not have actual adult, mature mast cells in your blood. That's a problem. But you'll have the immature ones that are trying to travel to their final destinations in your blood and your other tissues. They take up residence throughout our whole body. So it strongly resembles, and some people may get diagnosed with and also have histamine intolerance, because in the end, whether you're producing too much histamine or you're not out processing histamine, which is a histamine intolerance issue, you're lacking DAO and maybe MAO and HNMT. These are enzymes that help you process out histamine, even in a normal non-mast cell person. People can end up with the issues of excess histamine, which were all those pictures I just showed. So really, the symptoms I just described are really of excess histamine, for the most part. So we like to think of the body. We recommend patients think of their bodies as a histamine bucket. And you want to keep your histamine levels down if you're prone to this. Not too low, because we need some to stay alive. There's a condition called histaminosis, I think, or histopenia, excuse me, is too low, can cause various issues, including mental health issues. Histodelia is excess histamine. You'll want to look into that for mental health issues. I see a lot of kind of pseudo-bipolar behavior in our group, and I think histamine drives it. I think it's really just variations in histamine. I'm going to take a hard left turn and right now, though, and interrupt this mast cell programming to help differentiate from Ehlers-Danlos Syndrome a little bit, because we are finding this so commonly comorbid. It is not one-to-one, but if I had a nickel for every masto patient that vociferously, as I'm looking at them and talking to them, that tried to write off their frank dislocations and loss of cartilage and bursitis to mastocytosis, I'd be a rich woman. So I want to get folks to think in terms of connective tissue disorders. Ehlers-Danlos is a genetic collagen defect. It's actually, there's several of them. It's a collection of genetic collagen defects. We presently talk about 6 main types. There's several one-off mutations, and you're so rare that we're not going to talk about that. You know who you are. But of the 6 main types, 5 have distinct markers. But the last type, the most common type by far, hypermobile type Ehlers-Danlos Syndrome, which I technically have, we ruled out vascular and kyphoscoliotic in me based on my presentation and family history. I got the blood test, I'm negative, thank knock wood. But the hypermobile type by far can only be diagnosed clinically, and there's a lot of misinformation about this as well. I'll be a happy woman the day they get rid of the Beighton, B-E-I-G-H-T-O-N, 9-point hypermobility scale. And I just remembered that I have handouts that I forgot to pull out for you guys. Somebody remind me at the break to get my handouts out. I spent time printing this last night and I don't want it to go to waste. They're around here somewhere. I have so in a plot to confuse, the Beighton 9-point scale involves testing 2 fine joints and 2 large joints, and everybody gets hung up on this and how bendy you are. You can be a zero, nulla, null, nothing, nada, 0. On the Beighton 9-point scale, you can be a stiff zebra and pass the Brighton with an R, as in we got Brighton, England, diagnostic criteria for hypermobile EDS. Seriously, I'll go to my grave trying to pound this home. Yes, we hear about the most bendy patients. You'll see them doing circus acts and contortionists. Houdini was probably one of us. The rubber boy, Daniel Browning Smith, is one of us. And a lot of ballerinas, etc., dancers, performers. And I'm going to display flying bird hand sign for you. I suspect anybody who can bend back at the palm or knuckle. But a lot of us are stiff. We either stiffen with age. I used to be a circus performer as a child. I could do pretty tricks. I didn't perform for the circus, but for family and friends at Christmas. But I've stiffened with age, and some people like Dr. Jaime Bravo himself in Chile, who has this, never are. So I want to get that myth out of the way. So if you've got, prolapses, herniations, tears, strains, sprains, bursitis, tendinitis of any kind, loss of cartilage, especially in the knees, the hips, fibromyalgia. This is most commonly being diagnosed as fibromyalgia. I've yet to meet a fibro patient who does not pass the Brighton diagnostic criteria for hypermobile EDS, just saying. The problem is if you start reading it from the top down, it starts with the 9-point bendy scale, and as soon as people don't pass, their minds snap shut. So read it backwards from the bottom up and keep a tally of how many minor points you pass. Every one of them, their jaws drop and they're stunned. TMJ, subluxations, dislocations, don't sleep on your sides, you guys. You'll take your shoulders and your jaws out. Sleep on your backs. All right, back to our scheduled programming about mast cells. Thank you for letting me go there because, again, I just want to help patients know to suspect, and it can help with your therapy because you'll be treating a mast cell stuff, but your Ehlers is getting worse and you're not understanding. It's a biomechanical problem. The mast cells are a biochemical problem. I have a blog post called Solve for both X and Y. So this isn't a scientific diagram, but as I said, it's not one-to-one, but there's an awful lot of overlap. I'm hard-pressed to find folks who don't have both so far. And I believe that it spawns this third condition, postural orthostatic tachycardia syndrome, which is why I have a cot over here if anybody needs to lay down at any point, including myself. This is a subset of dysautonomia. Dysautonomia is dysregulation of your autonomic nervous system, which is what keeps you alive at night. It keeps you breathing without thinking, your blood pressure going, your heart rate going, your digestion going, your temperature controlled. The things you don't normally have to think about, we have to think about them. And POTS is a particular subset involving folks will often have dizziness upon getting up too quickly. People will have trouble staying upright for very long, and you'll get the blood rushes to your feet if you combine flaccid, weak veins and weak venous tone, along with possibly plasma loss from mast cell activation. Of course we have low blood pressure, and our poor hearts and brains scream for blood and go tachycardic. So I call that the love child of EDS and MCAS myself. That's just my personal theory, but it's a common, we call this the trifecta affectionately. But that's not all. We're finding, and this isn't just me observing this, but for whatever it's worth, virtually everybody I know with either condition is either on or related to somebody on the autism spectrum. I find this interesting, and I think that there's both biomechanical and biochemical drivers of the autism spectrum. I think that, like sensory processing disorder, you have those squished occipital lobes. You know, everybody, vision and hearing gets more sensitive, you know, when the brain juice goes up. Neurology, there's a study that's correlated hypermobility with increased amygdala, the size of the amygdala, which is your emotional seat of the brain, the anxiety and fear-driven part, your reptile brain, the thing that, you know, fight or flight reactions. So we have to really recruit our frontal lobes. Just putting it out there. So, what are mast cells? They're part of our immune system. They're big, blobby cells. They're born in our bone marrow. They're kicked out young when they're small and undifferentiated and immature. They all have a few granules in them. These blue and purple packets are granules. The big one in the middle is the nucleus. They'll migrate into all of our external facing tissues, your skin, lungs, eyes, ears, and your digestive tract, especially from lips to tail, all the way through. And they're, in a healthy person, they're what causes allergy, you know, which is a particular mechanism of activation of the mast cell. They're also activated by infections, viruses, and bacteria. That's why you have allergy-like symptoms when you get a cold, and you take those antihistamines when you have a cold. These granules contain what are called mediators, which is a fancy word for organic proteins and chemicals, that when the cell is triggered by whatever mechanism, and there's many, many mechanisms we're finding, not just allergy, they migrate out to the outer surface, and they will spill and release their contents out. And there are there's at least 60, probably 100, and up to 200 mediators, according to some scientists. They're still studying this all the time, finding their interactions. And as you're about to see in this list, the ones I put in red also turn around and act as additional mast cell activators. So it's like, it's not enough that we activate some mast cells, then they keep the party going themselves. It's like, thanks you guys. You know, like long before Twitter was around, you want to talk viral media, the mast cells have it down. They get their party started, and they also can talk to and maybe listen to basophils and eosinophils. So if anybody has eosinophilic disorders, that doesn't surprise me. We can have a lot of eosinophilic esophagitis in our group. Those are similar, kissing cousins, similar type of cell. On the left are some stored mediators. This is a very short list, as you can see. The most famous, histamine. You're going to, you know, be paying attention to it all the time now. Tryptase is one of the common mediators that they like to test for initially in everybody, whether you're master or mast cell activation. Serum tryptase is a common test. You should get one at baseline, and then try to get one in a flared state, but that can be tricky and dangerous. So you know, that's a tricky thing to do. And some of us, even in our flares, our tryptase may not elevate much or at all. Prostaglandin D2, that often drives some of the asthma and hair loss, by the way. I must be low in that because I'm blessedly spared from asthma. My lungs don't get involved until I'm really pushed. Heparin can lend to some of that bleeding and easy bruising, and combined with weak capillaries from Ehlers-Danlos, it doesn't surprise me to see purpura and bruising and petechiae. Corticotropin releasing hormone on the left there, mast cells release this, and we have mast cells lining our hypothalamus in our brain as well, and they'll activate that. Dr. Theorides is one of the leading researchers who's discovered this. How the mast cells get in the brain is a $64 question I want to find the answer to someday. That then drives through your pituitary, will drive your adrenals. So it doesn't surprise me we're hyperadrenergic, you know, and we'll have a lot of adrenal fatigue in the group. And you know, and even mast cells not in the brain can release more CRH. So it's kind of a perfect storm. I highlighted interleukin 33 on the right because I think I remember Dr. Theo just gave, we call him Theo for short, Theorides. He's a wonderful man. He's doing a lot of really good research in this field, and he's been discovering some of the mast cell stabilizers, natural mast cell stabilizers, And I believe he mentioned in his talk, and it's on my website, under the resources, I have his video, and if memory serves, I took a note earlier this month during the webinar he gave via Chronic Pain Partners, that interleukin-33 is notable because it kind of accelerates. It's like fuel to the fire. It accelerates and increases the reaction rate. So it's a driver of activation. So it's like it's not enough that they make us sick, but then they keep their party going, the buggers. So high-level overview, pulling back out of mast cell activation, allergies are one mechanism that triggers our mast cells. Everybody's heard of allergies, and a lot of us have them. So, but with mast cell activation disorders, patients can be negative for any IgE allergies, but still be as sick or allergic or reactive as an allergic patient, an anaphylactoid, if you will. And I'm going to show that mechanism in a minute. So that's one way that we activate our mast cells. And I have IgE allergies myself. I just learned recently, this was eye-opening for me, that there are some autoimmune disorders that can also trigger our mast cells, believe it or not. I don't have enough information on that, and we don't have time, so I'm not going to go further into that. I'm going to skip those for today, because that's another rabbit hole. And then we're starting to increase awareness of all the forms of mast cell activation disease, which fall into two broad categories. I'm going to try to sit. So sorry, if you can't see me, you'll see my little nose peeking. It's like a car that's I need to sit for a minute. Mastocytosis involves proliferation of too many mast cells. And in the cutaneous form, that you saw the spots of urticaria pigmentosa, that can be punch biopsied and checked. But not everybody has spots. Some people have essentially internal spots. That's your systemic mastocytosis. It's essentially that you've got clumps like those patches of urticaria pigmentosa inside your body. So then we get to go on a nice hunt for all of those. And they are also overactive for whatever reason we don't know yet. They're slowly, zeroing in on the mechanisms. God bless all the researchers and scientists working on this. They're trying really hard to figure out why they're overactive. We don't know yet. In Mast Cell Activation Syndrome, this is the new diagnosis on the block to most people. Again, you'll be symptomatic like a masto patient, but minus spots inside or out, so to speak. But your mast cells are definitely overactive, and you can be just as sick as a masto patient. In fact, some people are sicker. I've got friends with mastocytosis who are working full-time. I'm not. I'm on disability. I'm trying to get back to work, but anyway, it's not a contest, that's all I'm saying, and masto isn't necessarily worse than mast cell activation in terms of disease burden for the patient. So I never want to treat mast cell activation syndrome lightly. It can be just as dangerous in terms of anaphylaxis or anaphylactoid reactions. And you can have any combination of the above. You'll hear me mention Hickham's dictum later. Dr. John Hickam is quoted as saying, patients are entitled to as many diseases as they damn please. And, so this doesn't preclude you having other things, clearly. So pulling back out to allergy, that involves the secondary immune system. So mast cells are part of the primary immune system. They're the first reactors. They are recruited to sites of wounds and infection when you get cut or scratched or bit. They go there. That's when you turn red at the side of a cat scratch and a bug bite. That's histamine being produced. In allergies have to, where did my mouse go? There it is. Involve this triangular greenish shaped thing is called an IgE antibody. And so when you're first exposed to something you become allergic to, you will not react the first time. You may not even react the second time, because your body has to, for whatever strange reason, we don't know why it does, but it decides that peanut is a bad thing, and that's just the most common, that's why I'm picking on it. And so then the adaptive immune system, which involves a bunch of other cells and mechanisms I won't go into, because I can't, produces these antibodies that remember the face of that protein, so to speak. It's like, I'm going to remember your face. I've seen you before, I want to remember you. And those float around and are attracted to this FC receptor on the mast cell. It's an FC epsilon receptor, E for epsilon, epsilon for E. There's FCG or gamma receptors for IgG. And so that's how your allergies work. Basophils often do the same. And actually Dr. Driscoll of prettyill.com has posited a theory. She's wondering, has asked in her Driscoll theory, wonders if basophils may not be the party starters actually, and that mast cells then climb on board and join the party. We don't know. It's a good question. They can recruit other cells through chemotaxis, kind of like ants recruit other ants with little chemtrails. They the other cells are attracted chemically via the mediators being sent out. So, you've got your where'd my mouse go? There it is. There's your allergy, receptor. You've got other receptors. The toll-like receptors are what make the mast cell respond to viruses and infections, bacteria and infections. They're sensitive to the protein coats on bacteria. So again, that's why you get allergic-like symptoms with your infections. This KIT receptor you'll hear about in the masto world because a lot of patients want to know or find out, and you should want to find out, if you are c-KIT positive or not. It's a particular mutation of the KIT, which is a receptor on this cell. It's 816, codon 816 in particular. There's multiple mutations of KIT, but this one in particular, we have honed in and figured out that it causes the cells to proliferate by stopping them from dying at their normal programmed cell death time. Normally, they will not stick around unless there's stem cell factor floating around that they detect. With the KIT mutation, they don't know to leave. It's like people who come and overstay their welcome. They just keep sticking around and they never die off. So then you have a proliferation problem. So that's one of the drivers of proliferation. But only 80%, I mean, it's a lot, but 80% of patients with masto will have a KIT mutation. So there's 20% who do not have a KIT mutation. So being c-KIT negative does not mean you do not have a form of mastocytosis. And again, I like to point out that the mast cell activation disorders include non-protein triggers like chemicals, scents, hormones, heat, cold, exercise, stress, vibration, and sunlight. You can't form an IgE antibody to sunlight, folks. And often the other telltale thing is it's on first exposure. So again, you can't be allergic, technically IgE allergic, if we want to get pedantic, to something the first time you encounter it. So that's just to help differentiate. So we have lots of ways of activating our cells. And we're drilling down now into the forms of mast cell activation diseases. And I know this is hard to read, and I'm not going to go through the whole thing, but the clump at the top with the big arrow, curvy arrow, are the forms of mastocytosis, which fall into two broad categories: cutaneous, which are skin forms, which will involve the urticaria pigmentosa, but there's some other forms. TMEP, T-M-E-P, telangiectasia macularis eruptiva perstans, I think. I should get a piece of chocolate for that, if I got it right. And some other forms are visible. You're going to have these visible signs. And so hopefully you'll know to go to suspect and get those looked out. Now, some people with skin signs will also have systemic mastocytosis, possible. So again, we want to rule out systemic mastocytosis forms. And there's several forms, and some of them are more aggressive than others. And the most aggressive forms may require some chemotherapy to control them. So you may be ending up working with a hematologist-oncologist if you end up with some forms of systemic mastocytosis. Not everybody. And this third category, where'd the mouse go? Towards the bottom, just above MCAS, MMAS, monoclonal mast cell activation syndrome, is what you call people who meet some of the criteria for mastocytosis. They'll have some signs, interesting biopsies, either misshapen cells or some other signs, but they don't meet enough criteria for the full diagnosis of systemic masto. So those folks are in a kind of a hybrid space called monoclonal mast cell activation syndrome. And then again, the new diagnosis on the block at the bottom there, mast cell activation syndrome. You'll be c-KIT negative. You're not going to have evidence of any clusters of mast cells throughout the body. You may or may not have elevated tryptase or any other mediators. And I'm going to go into, trying to test for this in a little bit later. Then, within all of those forms, we seem to fall into two general camps of reactivity. And I don't know that this is differentiated, like if you have masto, you're a shocker, or otherwise. I think this runs across all types, but we tend to fall into leakers versus shockers. And the shockers, they know who they are. They're the frequent flyers to the ER. They go quickly. Their reactions are fast and severe, and they're often needing to use epi, and they struggle to stay stabilized. You can often have a secondary reaction, which is why your EpiPens are sold in packs of 2, folks. I'm going to get back up here. I'm going to get a prop. This was the box my EpiPens came in. This is a practice auto-injector, so this will not, there's no needle in here. And they provide one to help you practice auto-injecting before you need the real thing. And it's designed to go through your clothing. I'm lucky, I don't need to use epi much at all. I haven't had to for years. I still carry mine because we can still tip over if you stress me enough and give me enough triggers, and things can change. I want to be ready. But leakers will have the same symptoms, but I can, from my own experience anyway, and I consider myself a lucky leaker. You heard that here. Not speaking of my bathroom habits. I'll go through all the same issues, but much more slowly and across more time. And I think we can still have a biphasic reaction. And this is one of the reasons that when you're challenging foods, you don't want to add another new food sooner than once every 3 days, because it can take 72 hours for you to notice a reaction. It may be just that when it's transiting the colon, when it finally gets to your colon, you start to react. So you want to be careful when you're challenging things and trying to identify triggers, that you consume. You give yourself enough time between new substances to help differentiate what was I reacting to, the first thing or the second thing. Was it a biphasic reaction to the first thing or a first reaction to the second? And so this is a point of contention for me. Most medical literature and practitioners only call anaphylaxis the highest grade on this chart. And that's kind of all they really care about, because that's when they need to treat you, and that's when they see you in the ER. And I get that. We understand, if I'm not losing my airway, if your throat's not closing, your airway's okay, you're probably not going to die. But I think it's really useful for patients to know and learn the lower stages, and for doctors to recognize it, and nurses also, because this can help you recognize that you're starting to go and make sure you don't have additional triggers and that you stay calm and avoid it tipping over to a greater reaction. I just went through this last week. My doctor doesn't even know this yet. I started off eating foods that I shouldn't have eaten. I thought I could get away with at a friend's house. Bless his heart, he fed me dinner. Very gracious host. And I was like, I'm doing pretty good. I think I can get away with eating this food. And it was delicious. It was absolutely delicious. But sure enough, I had a mood swing, which, by the way, is another common sign. With this, children may get sullen, and we can get really irritable and angry, or just have a mood swing. And as I left his house, and so then I ended up crying on the way home because I was upset about having a mood swing. I'm frustrated with that. I don't want to be that way. So that got me worked up more. And I say that because I've heard people in the groups, I've seen people post that they literally cannot cry or laugh without going into anaphylaxis. Some people are that sensitive to stress. And so, but I'm still thinking I didn't have any issues yet. I didn't have any gut reaction going yet, any more than my usual. I'm always in gut pain. And then I got home, and somebody had burnt something in their kitchen, and there was an odor in the hall. And I'm generally lucky. I don't tend to react to scents and odors as much as other people. I don't carry a mask yet. I'm just learning about them, as Andrea knows. I'm going to look into one now, because the second I parked my bike and I was going in the back door and I have to walk the long hallway to my apartment, I instantly reacted. My airway instantly, blam. It was not even a second. It was instantly barking like, I couldn't breathe, literally, and gasping for breath. Just, it went. And so I knew what was going on. I was like, oh wow, I didn't think I was reacting to odors yet. But so I got to my apartment. Thankfully there was no odor in my apartment. I swipped some Benadryl and avoided my EpiPen. I knew to stay calm. And I was like, well, that's odd. I didn't have any GI reaction. Not yet. So sure enough, I spent the rest of the night having GI reactions. So you can go in and out of these phases, and I realize you can't read this tiny print on the screen. This is going to be, again, I'm going to put my slides in on my, available on my website. By the way, welcome to the folks who have slipped in later. I knew people would filter in. Do me a favor later on and sign in the sign-in sheet. I'd love to know who you are, and kudos to everybody who traveled today. I really, really appreciate it. It's huge, and an honor to have you here, because we are very sick patients, and it's lucky if we can get out sometimes. So the first grade here, everybody, you'll always have your skin signs at the first level in all of the charts. You can Google anaphylaxis charts and Google, grades of anaphylaxis and see multiple, takes on this. There's no single authority that consensus, but so this is one example chart. You'll get your flushing, you'll get your itching, you might get some allergy-like symptoms, the coughing, itchy, runny nose, sneezing. You'll have nausea, cramping, according to this chart. And this one blessedly lists headache. I'm really glad to see that, because not everybody mentions headache as part of anaphylaxis. They move you to stage 2 here when you start to emit things, when you have vomiting or diarrhea, when you start emitting, and when your asthma kicks in for those with asthma, or you start to have airway involvement, but it will still respond to your dilators, your bronchodilators, your asthma inhalers. So if you're still responding to your asthma inhaler and you're able to control your airway, they consider that grade 2 here. Again, this is one example chart. They call it grade 3 when you stop responding to your bronchodilators if you have asthma. So you're using your inhaler and it's getting worse and you're going down. Those without asthma, like I had just last week, your airway's going. You might be spasming, you can't get air in, and you may start having your throat swell, and so you're going to start struggling to get air in at all. I can't tell anybody when to use an EpiPen, but I'm thinking I would be having mine handy, and I may consider using it for sure at stage 3, because at stage 4, your blood pressure is dropping, and I can't read this, but respiratory failure. So you're going down. And the last one is death. I love that they even bother listing that. It's like, okay, that's a little late, folks. It's a little bit moot. Here, let me get my EpiPen. So this is just one sample chart. And again, the value to this, granted, the doctors and nurses we see aren't going to call it anaphylaxis when we come in these lower grades. They're going to just say, oh, you're just anxious. And we may have anxiety. In fact, some patients report a sense of impending doom with their onset of their anaphylaxis. I'm willing to bet a lot of anxiety cases in the ER are low-level anaphylaxis, because you can get chest pain. You should definitely rule out heart trouble, but a lot of patients will go in with a heart pain, chest pain, and they'll just get written up as having anxiety. Well, I would be looking for these signs, see if you've got other signs. This is another sample chart you can look at later. So as you can imagine, we're the canaries in the coal mine. And the most sensitive patients, I like to say, somebody brightly said in our group, we're like the canary's canary. If the canary had a canary. We have patients who are that sensitive. And that's why they're not here today. Bless you guys. We wish you well, and we know you wish you could be here. This is not a chart, but it's the same stuff listed. The TMS notes that not all symptoms need to be present for anaphylaxis. It's usually considered once 2 organ systems are involved. So skin and GI, or GI and airway, or airway and skin. Once you get 2 organ systems involved, anaphylaxis is considered. They also note wisely, however, that some patients accelerate quickly. So you might start with hives or flushing and quickly accelerate. So I really wish we could have anaphylaxis management classes like we have pain management classes. That's a dream of mine one day. Because there's multiple tools in this toolkit. There's ways to manage at the lower levels. If you're a slow, reactor like me, how nice to know. That's why I've been able to stay out of the ER. My doctor hasn't seen me for 6 months. I mean, it's great. I'm an infrequent flyer now. Thanks to learning tips and tricks from the groups in the Mastocytosis Society, I've been managing myself well enough. I have plenty of reactions. I pass out a lot, but not suddenly. So I'm doing well at home. Now, this is where we get into sticky territory because I'm not a doctor nor an expert, and this is the $64 million question that even the best experts this is a moving target, is what I'm trying to tell you. It's an art more than a science. They're trying to zero in and make it a science as best as they can. But, so you want to rule out and acknowledge and recognize and differentiate allergies and sensitivities. Probably want to rule out carcinoid syndrome because it involves lots of flushing, and there was another symptom that's common. So it can look like, kind of like we can look like lupus, we can look like carcinoid syndrome. Suspect and rule out any forms of mastocytosis before considering Mast Cell Activation Syndrome. Now, I wouldn't go giving everybody bone marrow biopsies right out of the gate. I can't tell you when that should be done, but I would say that working with your doctors, and if your doctors aren't sure, have them consult the Medical Advisory Board of the Mastocytosis Society, which, by the way, is listed at the TMS website. Let me pop out and go there. On the internet. I can't see the... You must be this tall to write this right. Here we go. So doctors will want to click on the logical button, the physician's button. And there's great information here, including the Medical Advisory Board. We request that patients don't go calling these doctors. If you're not on board as a patient of these doctors, these people are generous volunteers. They are swamped. They've got the most credible cases in the country, and they are volunteering their time to act as advisors to other doctors. So please, patients, don't just go picking up the phone and emailing these guys and adding to their workload. Have your doctors do that, unless you are going to get established with them as a patient. By all means do, if you can see these specialists or need to, do so, but we want to kind of try to keep their workload down. Have your doctors consult them. This is who they can consult, when you've landed in the ER and they're not believing you about this and that and the other, have them talk to these people. These are some of the very best specialists in the country and the world. That includes Dr. Valent over in Austria. And one of them is outdated. Dr. Afrin has moved to Minnesota. He's no longer in South Carolina. So these are people that doctors can consult, both in emergent and non-emergent times, preferably non-emergent. And ideally, like I said, I dream of getting a conference out here so we can have some of these experts speak to you about how to diagnose. So again, commonly, we'll check a serum tryptase level both at baseline and ideally during a flare. But again, depending on how anaphylactic you are, we don't want to endanger your life. Please take care, to do that. And that's what's hard about this. It's hard to catch somebody at the right time. And even if if you're a slow reactor like I am, it's kind of like trying to catch a wave. Imagine a wave in a swimming pool that travels forward and you've got a rubber duck being propelled by it. If you don't have a blindfold on, you can see the rubber duck and reach out and grab it. But if you have a blindfold on and you're told to catch the rubber duck, you can't see it. In other words, you don't know when the mediators are going to pass out through the bladder, when they're being processed out. So it's a little hard, it's an art. You may take several tests. So I'm not a doctor, but I would recommend the 24-hour urine histamine catch, because the spot catches. If you just do a spot check of your urine, you may or may not be catching that wave of mediators. So that might be one reason patients get negative results, is if it's not perfectly timed and we don't know when the mediators are coming out of you, it's hard to be sure to catch them there at that time. So a 24-hour urine methylhistamine catch is best, because you have a chance of catching that wave whenever it's in your body. I have heard from multiple leading sources that you really need to keep these mediators chilled because they disappear within 2 minutes at room temperatures. So Dr. Afrin said at the 2012 conference anyway that he recommends you keep the P basin chilled and the P jug chilled. Pull it out only when you need to use it. Pour the urine into the storage jug, immediately put it in the fridge, wash your basin and immediately refrigerate and keep chilled. And then you have to keep it on ice to your lab, and you hope that your lab keeps it on ice, and that any FedEx truck it lands on keeps it on ice all the way to its final destination. Because Dr. Afrin and others have learned the hard way that they had very, very sick patients with really clear signs. They were definitely sick, definitely had elevated mediators, but if the sample lost integrity on the way, they got a negative result. And imagine, we don't want to spend thousands of dollars, needlessly. So I have heard rumor there's some preservatives that can be used. I don't know. So that's, again, consult the specialists. Some people who suspect systemic masto, again, you're going to be working with a specialist on this at this point. You started with an allergist, immunologist. You'll work your way to probably a hematologist, if you're suspecting masto. And those folks, when warranted, will maybe want to look for the c-KIT mutation. It's a particular genetic test. As I mentioned before, only 20% of patients are negative for c-KIT, the c-KIT mutation, but still have systemic mastocytosis. So negative result there does not mean you don't have masto. About 80% have that. Again, it lends to proliferation. And I don't know when to, a bone marrow biopsy is warranted. So I can't answer that, I'm sorry. And again, work with specialists, consult the medical advisory board, join the Mastocytosis Society. And another note from the field from the doctors was that oftentimes another reason folks don't get diagnosed easily or readily is because even when you get a good biopsy, whether from the bone marrow or from other patches in your body, your GI tract for instance, they need to know that you're looking for mast cells, because if they don't know that, they won't stain the slide correctly and they won't find the mast cells. So they'll say you're perfectly fine, you have no trouble, and if they didn't stain right, when you go back, you can resubmit. The patients have had that happen where the doctor wisely reordered the test, said make sure you use this particular stain, then the mast cells showed up. So these are just pro tips from the field. Again, I dream of getting a conference out here, because I'm not qualified to give precise answers on this, and I'm sorry. Again, if all of the above are negative, if you're negative for signs of mastocytosis, but you're still symptomatic like a masto patient or really high histamine, and respond to what we call the H1H2 protocol, which is antihistamines for both. So it's your normal antihistamines plus the stomach antihistamines, which are Tagamet, Pepcid, and Zantac. Consider a presumptive diagnosis of Mast Cell Activation Syndrome. Again, I'm not a doctor, I'm not a specialist. Consult the doctors, the specialists. As I said at the bottom, this is a very incomplete rough guide. Consult the Mastocytosis Society for assistance. This is, and it's hard to read, but this is a table from a 2011 paper that really summarizes the WHO criteria quite nicely and essentially says the same thing I just did. So don't take my word for this, read for yourselves. This is all on my resources page as I showed you before. So moving into some common mast cell triggers, I want to put a word of caution here. Don't go eliminating whole groups of food in a wholesale fashion if you do not have to. These are just common themes we see in the group. A lot of people tend to react to tree nuts, your pecans and your almonds. People will have a problem with salicylates. Some people will have a problem with some oxalates. But don't necessarily eliminate the whole class. Try, if you're not too sick, if you're not too reactive. Try to keep as many foods as you can. I'm stealing Wendy's thunder. She's going to be addressing this more at length later, and I'm looking forward to it. But in general, all foods increase in histamine when they're leftover. So avoid eating leftovers. Try to freeze your foods if you're keeping them leftover, and then rethaw them as needed. But meat is especially high histamine because just like us, a lot of the animals have mast cells. When you cut the meat, you're breaking mast cells, they're releasing mediators. They probably don't have mastocytosis, but again, it produces the histamine. So think about it, hamburger. No wonder I always got sick with hamburgers. Now I know. And leftover hamburger would be the worst. So I have a death wish when I order a hamburger with tomato ketchup and a glass of red wine. my other dish of choice would be, my last meal would be lasagna, leftover lasagna. So yeah, my days of eating Italian food are over, sadly. And I used to be a foodie. I ate my way through France once upon a time, and I'm so glad I did. So, because my diet is much reduced now. It's still pretty good. It's much better than many, but vinegars and yeast and mold are also common, so aged cheese and blue cheeses are a common trigger, and alcohol. Again, in the non-foods, your bees and wasps and iodine, a lot of anesthetics. It won't be the same for everybody. Various chemicals and fluoride and chlorine. I just got done figuring out the hard way that I react to chlorine. I lost about 10 pounds. And I've got them back now, but I was struggling to eat at all because I was so inflamed. And I finally found a water filter that works. Brita does not filter out chlorine. And Portland water, it does not outgas when you leave it sitting on your counter. It's a chemical. You have to actually chemically filter it out. So I found it's called a zero water. That's working for me, but I know another patient who can't use the zero water. She reacts to something in that it's made from. It's a competitor to Brita. It's a 5-stage filter. I have a container on my counter, and I pour the water in and it comes out the bottom. But that's working for me, but that may not work for everybody. So this is going to be trial and error for everybody. Heat, cold, stress, vibration, and pain. I may not have pointed out during the mediators before that substance P is also not only produced by mast cells, it's also a mast cell activator. So imagine your Ehlers-Danlos patient who's in a lot of pain. Gee, it's increased by your mast cells, and vice versa. So, and even people without Ehlers-Danlos but mast cell activation have a lot of pain of all kinds. I think it lends to fibromyalgia personally, and we see a lot of complex regional pain syndrome in the group, and even arachnoiditis. So, interesting. Treatment strategies. Again, I'm not a doctor, I can't prescribe anything, I can't tell you what to take, but strategies. Identify and avoid your triggers as much as you can. Foods are obvious. You're going to be, trying various methods to identify foods. If you struggle to eat whole foods, or if you don't have control of your cooking because you're dependent on someone, try to do a food journal to notice, like noticing every time you eat Italian food or tomato paste, you're having a problem kind of thing, or every time you eat nuts, tree nuts or almonds, you have a problem, that kind of thing. Avoid orange and red dyes, including in Benadryl. I'm lucky, I don't have a corn allergy, so I can still use children's dye-free liquid Benadryl. People with a severe corn allergy will still react to children's dye-free liquid Benadryl, but the rest of us, this is great because being liquid, you can use just as much or as little as you need, and you can get it down your closing throat, as opposed to a pill sometimes. But some people react to all of the additional ingredients, so they end up compounding their Benadryl, going to a compound pharmacy to get a form that they can take. And somebody just pointed out that they take capsules of pure Benadryl, they literally chew on it. It tastes terrible, but it keeps you alive. You want to eat a nutritious diet. Whole organic foods as much as possible. I realize this is really hard for folks who are working. I'm lucky, I'm on disability. I spend a lot of my time in the kitchen and recovering from being in the kitchen. It's very exhausting. Because that way you're not eating complex meals, you don't have any added ingredients, so you can identify what you're triggering to. Plus, it's really good for everybody to eat organic whole foods as much as you can. But I realize it's labor intensive. Detoxify your home if you can. Make sure you're using, eco-friendly cleaners, body-friendly cleaners. We might react to chlorine. You can try using vinegar to clean. There's lots of groups and techniques for that. H1 and H2 blockers is medical speak for antihistamines. The H1s are your over-the-counter traditional antihistamines: Claritin, Zyrtec, Benadryl. I take chlorpheniramine maleate. It's an old school over-the-counter. It used to be called chlortrimeton, and I find it has helped me to sleep really well because it's sedating with no hangover in the morning. And I'll take one capsule of that at night, one tablet. It knocks me out and helps me get through the histamine dump around 3 o'clock in the morning. You naturally shed histamine, even healthy people shed histamine around 3 o'clock in the morning. So you might notice you wake up coughing and choking around 3 o'clock in the morning. That might be your histamine dump. The H2 blockers are Pepcid, Tagamet, and Zantac because the stomach produces acid in response to histamine. So those H2 receptors get blocked by those medications. Mast cell stabilizers. Dr. Theo and others have found that a couple of bioflavonoids, quercetin and luteolin, are proving to be very effective. In fact, he says more effective than cromolyn sodium, which is a prescription mast cell stabilizer that a lot of people use. You can get cromolyn sodium for the eyes. It's octochrome. You can get it for the nose, nasal chrome, and for the stomach, gastrochrome. People get different results. Every body is going to literally be different. You have to try things for yourself, see if it works for you, see if you react. No two people will have the same treatment pathway. This is a process of trial and error. You need to be patient and think marathon, not sprint. And then there's a couple of prescription antihistamines that the group finds often work well, are Atarax and Ketotifen, which is a special order. It's from overseas, but some people have great benefit from it. Again, everybody's going to be different. Some people will react to any and all of these things. You have to try and see what works for you in consultation with your doctors. And then I would urge everybody to try to reduce your stress. Set good boundaries at work and home. Try to engage in some meditation, calming. Take some time out to just calm, get out of the storm of life, get off the rat race, And so mindfulness and yoga practices as able. I find energy work to be very helpful. I got acupuncture years ago. It was a big help. I got rid of my nasal allergies. Reiki, Qigong. But keep active, meaning keep your exercise levels up as tolerated. All of us need to still stay active as we can. Even I do. I now bike and swim better than I walk because of my Ehlers, but that's what I do. And I do more water therapy. Find what works for you, obviously. And those who are in the most serious states of Ehlers-Danlos, it's going to be individual. Work with a physical therapist who understands hypermobility. Have good sleep hygiene. Try everything you can to get the best sleep you can. Controlling pain, controlling mast cells, which will control pain, will help you sleep better. Having lower histamine. I immediately slept better when I went on an elimination diet, and my pain levels reduced. So I started to sleep better, which helped everything get better. It's an upward spiral. Triage your problems at the doctor. Pick your top 3 at any one time. We are really complex patients. They can't solve everything at once. And they're good, hardworking people, but they can only do so much. So pick those top 3 things that are bugging you the most, that are the most show-stopping, that you want to work on. Do something you love every day. Make sure you're enjoying yourself. Have a hobby, whatever it is, whether it's sport or knitting or art, music. Make sure you're having a quality of life a little bit every day whenever you can. I know this is really hard when you're sick, and especially if you're a parent. And again, think marathon, not sprint. I've already talked about the histamine bucket. This is a restatement of everything I just said. I'm going to go into comorbidities, and I don't mean to alarm anybody here, but those who came in late missed my part at the top where I showed that we often have comorbid Ehlers-Danlos. Not always, it's not one-to-one. So I'm going to go right away to the trifecta, go back to the trifecta. We find these commonly comorbid. Again, it's not one-to-one, but there's an awful lot of overlap. But we also see the following really common. Autism spectrum, as I also already noted, for whatever reasons, is commonly comorbid. And by the way, the luteolin and quercetin, there's a product called NeuroProtect. I have one of the empty bottles over here. A lot of patients find that they clear their brain fog and improve their speech. And a lot of the autistic community, the children, they're finding that children will gain speech or regain speech on NeuroProtect. I have no financial stake in this, but it's just, this is reports from the field. That's a product that has luteolin and quercetin and rutin and a base of olive oil. We also see a lot of people show signs of common variable immune deficiency. This is another immune disorder, and for what it's worth, the NIH is studying the comorbidity of Ehlers-Danlos or connective tissue disorders and mast cell disorders as we speak. They've got my blood, and I've been in touch with one of the doctors there since being entered as a patient, and he confirmed he's seeing the same thing. So everything I'm observing here, he's observing also in the study. I said, you know, I see this really common. Are you seeing it too? He goes, yes, we are, and we don't know why it is. But common variable immune deficiency leaves you prone to chronic and recurrent infections, and you have trouble fighting them off. Well, golly, so it's like we can't win for losing. You're prone to infections, you get infections, that increases your mast cell activation. So no wonder we suffer. And all of this leads to incredible levels of chronic inflammation, which leads to the last common comorbidity I see is all forms of autoimmune disorder. Everything in the book, in the group. You can ask in any of the support groups who's got an autoimmune disorder. In fact, you know, if anybody wants to do a show of hands here, almost everybody's got some form of autoimmune disorder. Lupus, Sjogren's, MS, variations on that, you know, even ones that don't have names. I just see all autoimmune disorders really common. I think it's from all the chronic inflammation. And toss in, you probably have leaky gut from stretchy tissues if you have Ehlers-Danlos. You know, it's quite a package. So, you know, but that's why I want people to be aware of this, because as you can imagine, doctors will see you for any one of these things individually and not necessarily recognize the rest is going on. So you may have heard of the 6 blind men and an elephant story. I like to talk about 60 blind men with our elephant. We've got so many things wrong and so many issues. We'll see almost every specialist of every flavor at some point in our lives, thanks to this burden. So there's even a group called the Elephant Project, by the way, on Yahoo Groups, of really smart patients and doctors who are collaborating, trying to figure this all out and figure out who's driving what. You know, we're not sure what's the root of all of this, but I accordingly recommend a functional medicine approach overall. And again, remind you of Hickham's dictum, which is that patients are entitled to as many diseases as they damn please. You may have things other than this as well. I mean, trust me, it doesn't stop here. I can't preclude you from having, arthritis, by the way, is autoimmune, usually autoimmune and very common with both Ehlers. It's early onset with Ehlers. And Occam's razor, which, to paraphrase the brilliant Dr. Afrin, is essentially, do you really think there's 57 different things wrong with your patient? Or could there not be 1 or 2 underlying systemic disorders? So when you're starting to see a lot of disparate issues, including mental health issues, by the way, you know, look for an underlying systemic problem. Somebody in the Ehlers community wisely said, if you can't connect the issues, think connective tissues. Whoever you are, you're a genius. We don't know who that is, so we want to give proper credit if anybody knows. These are my resources, which are on my website, which I already showed. My website is ohtwist.com, ohtwist.com. Look at my resources pages, both Ehlers and the Mast Cell resources pages. I keep that up to date as much as possible. And again, there are some specialists for you to consult here, including some Ehlers-Danlos specialists, some organizations, including the local support organization for Ehlers-Danlos, who are meeting today at 3. All right, thank you.